Hi, and welcome to the Oregon Sexual Assault Task Force's Healthcare Provider Training. This is Module 8, Medical Documentation of Sexual Assault. My name is Nicole Broder, and I'm a Sexual Assault Nurse Examiner and the SANE Coordinator at the task force.
Hi, and I'm Dr. Aoi Mizushima. I am a SANE trained family physician.
So in this module, we'll be discussing documentation of medical care for a patient seeking care after a sexual assault. We will talk a little bit about what and how a provider should document their own findings with the patient. We'll discuss what the SANE is going to document with the patient. And then using that, we'll explore expectations around documentation when a SANE is not involved, as that does influence then what the provider will need to cover with the patient and document. Finally, we'll talk about some privacy considerations and logistics relating to documentation, such as the patient chart and photographs, and we'll address some common questions about court testimony. So one point that I really like to make with SANE trainees as well as providers is that documentation is evidence. It's very tempting in working with a sexual assault patient to see only physical evidence collection, such as swabs or clothing, as evidence, but really our documentation is as important, if not more important, than those pieces of physical evidence. That means that it's really crucial to document well. And that can be difficult sometimes when we're all juggling a very fast-paced medical environment. The good thing is that what I've heard from both SANEs and providers that I've trained is that in talking about how to document sexual assault documentation well, it feels like they improve their documentation overall in the medical environment, which is always a good thing.
As far as provider documentation, it's really important, and this can be super hard as a provider who's used to taking in all of the history and making your assessments based on, that there's so much in that history that kind of helps guide where your exam's going to go. But knowing if you already have called the SANE, the SANE is on their way, or that they're outside the door already, it's really, really critical to kind of keep your part, as the provider, kind of minimal. It's totally fine to ask a patient any questions that you need to assess their initial stability, any immediate medical needs prior to the SANE exam, or non-urgent medical needs following the exam. But it really does not need to be your role, and it's encouraged to not go into a whole bunch of questions about very specific things about where the assault occurred or exactly what happened, but just kind of introducing, kind of letting the letting the survivor know that you can always do a quick check-in and asking something like, is there anything urgent that you want me to take a look at before the SANE comes in and does their full assessment. It's really, you could take a quick listen to their heart, lungs, look at their vitals, all of that normal stuff too, but just really kind of keeping trauma-informed care in your mind, in your forefront at all times, just kind of knowing that every single time this survivor has to repeat their entire history, it can really be re-traumatizing. And they may have already repeated it a couple of times, maybe to a police officer, or maybe when they first called in on their way into the clinic or the hospital setting. So it's really important just to kind of keep your own questions at a minimum. It also really will help keep you out of court if you start recording a very long, detailed history of exactly what the patient is saying and where they're describing their injuries, and you start kind of diving into what their injuries look like. It makes you, and just like Nicole said, the documentation that you're putting down, that's all evidence, and so it makes it much more likely that you would be called in to testify. So just really keeping minimum questions, and then also, beyond the above needs, just kind of also trying to not duplicate the charting that the SANE is going to be putting down as much as possible. And not only does it help prevent you from getting called in to testify, but it also helps prevent possible contradictions that might appear in the charting. And then just documenting objective observations and using neutral language as much as possible and avoiding conjecture. Knowing that the trauma response can be kind of all over the place. Somebody might come in laughing or crying, and there have been some times when providers will put in their documentation of that survivor something along the lines with, patient's demeanor is not consistent with somebody who has just been assaulted, or just making any assumptions, just staying away from words like the patient appears very sad or very anxious, and just keeping the language very neutral, very objective, just saying, you can document the patient is crying or their voice is raised or they're shaking. It's okay to kind of just document what you're seeing, more of like a mirror reflection rather than making decisions about what you think you might interpret from those behaviors. We can go to the next slide.
So following up on those notes about objective charting, one of the reasons that it's so important to reflect objectively the behaviors that you're seeing in the patient, rather than assuming you understand the emotions behind it, is that, as Ali mentioned, trauma responses vary wildly, and neurobiology of trauma leads to a huge range of responses that are all entirely normal after a sexual assault. And so by doing that objective charting, really just putting down the patient's behavior and not reading into it too much, it just helps keep things more accurate, because we can misunderstand what we're reading in people's emotions, and then that can be used poorly later. So if they make a statement about how they're feeling, you can certainly capture that in quotes. For example, per patient, I'm feeling so upset right now, I can't believe this happened. That's totally appropriate. But I would not chart the patient as upset. I would say the patient is pacing the room, wringing their hands, something like that. Remember that it's never appropriate for a healthcare provider to record an opinion about whether the sexual assault actually occurred or not. We are there to provide medical care for the complaint. The complaint is sexual assault. That's all we need to do that's all that we need to know in order to do our job. And it's not appropriate to make an indication in the chart that you don't believe the patient or that you do believe the patient. We just provide our care regardless. A couple of other points about neutral language. Remember that alleged is a legal term, and so it's never appropriate to use it in medical documentation. Sometimes I've seen in charts alleged sexual assault. The patient comes in with alleged sexual assault, but I've never seen any patient come in with alleged chest pain. So again, remembering that sexual assault is the chief complaint, or maybe a secondary complaint of this patient, and that we're treating that. Now, I do understand that some charting systems have automatic terminology that you have to put in for a chief complaint, in which case you may not be able to avoid the term alleged if that is what happens to be in that charting system. But if you have a choice of whether or not to use the term alleged, stay away from it. It's not a medical term and has no place in our charting. Remember also that the patient should always have choices in the care they seek. And I know that this is something that we've touched on in a few modules already, but it's worth repeating, that the patient may not make choices that you fully understand or that you fully agree with, but one of the key parts of our roles as medical professionals in dealing with a patient who has experienced sexual assault is to help give them their bodily autonomy back, because that's likely something that was taken away from them, however temporarily, in the course of the sexual assault. So making them feel empowered and supported in their own choices about their own body is incredibly important to avoid re-traumatizing these patients and help support them on a path of health and healing. So towards that end, when a patient elects not to take a certain option that I'm giving them, which could be a part of the exam, it could be a medication, I do not document that the patient refused, because that implies that they should have accepted the option I gave them. Instead, I use the term that the patient declined. So it could be patient declined STI prophylaxis, patient declined an anogenital exam. Decline just has a little bit more neutral of a tone and helps reinforce the fact that the patient absolutely had the choice to accept or decline it. They declined it, there's no judgment around that. So as far as what the SANE is going to be documenting, you can expect the SANE to be going through this list as part of their chart. Oftentimes, SANEs are working with a paper chart, which is not common in many areas in many other areas of nursing, but remains the most common way for SANEs to document their medical forensic exam. And these are all components of that chart. So one is that the SANE will discuss with the patient what activities they may have participated in that affect evidence collection. So it's typically things that the patient has done between the time of the assault and the time of seeking medical care. Sometimes patients seek medical care very quickly after an assault. More typically, they will often wait a while, sometimes a few days, sometimes a few weeks to seek medical care because they're processing that trauma and they're working through their different choices. And so that means that they may have been changing their clothes, bathing, brushing their teeth, eating, drinking, vomiting, lots of different activities that could affect evidence collection, could affect their physical assessment. And so the SANE will be discussing that with the patient just so that as the SANE is going through the exam, they are most informed about where they need to be focusing some care, where they can expect things to maybe have been altered. The SANE will also be going through a very detailed assault history with the patient. And that's why we really ask you to not go through that history with the patient if at all possible. Now, some patients do really want to tell people what happened. It's part of how they are processing their trauma. And so I would never say that you should cut a patient off who is starting to disclose to you about the assault. But knowing that the SANE's documentation is going to be very detailed, very in-depth, it's helpful for you to gently let the patient know that the SANE is on their way and we'll be talking over this stuff in depth, so that if the patient doesn't feel like they're in a spot to go through that again and again, they know that and they can maybe save it for the SANE who has more experience with that documentation. And some of those questions get very personal. And so building up a rapport is also incredibly important to help the patient feel supported in that. The SANE will be documenting an affect assessment, which again is very objective. So we train our SANEs to, once again, not say that the patient is anxious or angry or sad or happy, but instead really document the behaviors that they're seeing, the objective rather than the subjective interpretation. There are also several different risk assessments that the SANE will go through with the patient. One is risk for drug-facilitated sexual assault, which is something that the SANE will be considering if there is any reported memory lapse or some sort of altered consciousness during the course of the assault. We'll also do a risk assessment for strangulation, so checking if it was ever difficult for the patient to breathe, if there was ever pressure on their mouth or their neck or their chest or their back that may have impeded their breathing, or if there was memory loss. Again, we always assume that strangulation could have occurred during that time and that the patient would not have a memory of it. And that can be very significant and can be life-threatening. So it's something that we take seriously. We'll also be documenting any physical findings as we do a physical assessment of the patient and any evidence that we collect as well with the patient's consent. And then the final risk assessment that we do, which we tend to do towards the end of the history with the patient, is a risk assessment for HIV exposure. And so that can include things like behaviors that they know that the assailant engages in. It could be whether there was penetration or ejaculation. It could be things like they know that they have a history of IV drug use, and we know that that can increase risk. And it could also be things that we are noticing as medical providers, such as open areas of the skin. So there's a lot that the SANE documents. As of 2020, the chart is 16 pages long. And so know that we will be going into quite a bit of depth with the patient, and that's why we ask you to keep your portion as limited to the really urgent, immediate needs as much as possible.
So everything that Nicole has gone through is kind of in the ideal setting. I know none of this is an ideal setting, actually, if we're here in this setting at all. But but just all of the steps that Nicole outlined, it's great that SANES will cover it, that level of in-depth review of everything, the history, the physical exam, all thinking about all the different needs potentially that the survivor will need in the moment as well as afterwards. So it's great when there is a SANE around who you can work with, but there's going to be times when there will not be a SANE available. Either there's not a SANE available in the moment, or it might be somebody, in our setting, we're fortunate in that in our student health center, we can, because it's not like an immediate thing that has to happen. Sometimes if somebody walks in and the clinic is about to close and they just want to know like the number one things or the number for 1, 2, and 3 things that people usually come in for, they will want to know, am I okay? Do I have an STD or an STI, and am I going to get pregnant? Those are the very first and foremost things that most survivors come into our setting wanting to get addressed. And then we kind of take that initial, we kind of do everything we can to just take care of the initial things and then offer right away, calling an advocate, talking about what the SANE and the role of the SANE. So every setting is going to be different, but sometimes we can have the survivor come back the next day for the SANE exam if you're kind of within the time frame there. But there are going to be times when even with all of that, there still is not access to a SANE, or the survivor refuses and is not interested in having a SANE be involved in their care for whatever reason. And so it's going to be up to you to document without a SANE sometimes. And a lot of it kind of just falls with everything that we've just covered in the previous slides. But you will be ending up documenting a lot more than you would have otherwise. And you can review slide 4, where we kind of went through the provider documentation guidelines. But just making sure that you use kind of everything, kind of like I mentioned, kind of a mirror reflecting back at what the patient is saying, what the survivor is saying, is kind of what is recommended to kind of document. If they're saying something very specifically and they're using, cuss words, or they're, it's okay to just, it's recommended actually not to try to sanitize the patient's language at all, and really just use direct quotations whenever possible, and really trying not to paraphrase kind of what they said and then put that in quotes, as well as really avoiding anything that's going to try to make their chart look better or make them appear better. It's really just kind of documenting exactly what they're saying, keeping that neutral kind of language in there, not making any assumptions about what they're showing on the outside with what, crying or laughing or anything like that. Just kind of keeping it exactly as they are presenting is kind of what you're documenting there.
So then in terms of logistics around patient privacy and the storage of these exams, something to keep in mind is that these sexual assault exams are extremely personal and should not be easily accessible. And so different facilities handle this in different ways. Just a few examples. There are facilities that do not include any sort of electronic record of the SANE chart and instead just hold on to a physical copy that they lock away. That way it's accessible if it's needed, but it can't accidentally be stumbled across. Some people some facilities who are using Epic may institute a break the glass around the sexual assault medical forensic chart, so that if someone does access it, there's a record, and if someone's accessing it without a good reason, then that can be tracked back. And then there are other ways as well that facilities handle that in terms of putting up some extra layers of protection, some extra firewalls, sometimes storing it electronically, but on a different server. So it's good to just know your facility's policies for how to adequately protect that documentation. Typically, that's going to be mostly around the SANE's documentation rather than yours, because again, the SANE will probably have much more detailed documentation, but it's still something that's good to be aware of. And then lastly, I want to touch on testimony, just because I know that this is another area that I often hear concerns from providers. First of all, as we've mentioned a couple of times, the less that you document around this patient and the more that you leave the really specialized documentation to the SANE, the less likely that you'll have to testify in court, which is great for you, because as much as you are a very important part of this provider's process medically, medical forensic care is a specialty, and so it's always just going to be easier if the specialist, in this case the SANE or the SAE, is the one to be testifying in such a high stakes situation. But the good thing about all our discussion on documentation is that if you follow these suggestions, then even if you are called to testify, it will help you testify really accurately and defensively. And as medical professionals, we know that we could be called to testify on any patient that we see. But it is true that this patient population involves a little bit higher of a chance to go to court because we know that a crime has been involved and that they may be reporting to police. They may not, of course. And what oftentimes happens is that it may be years after you've seen this patient when you are testifying. And so when you have this really objective charting, when you're very clear about what information you got, what you left to the SANE, how you're charting information that you received from the patient, it just really helps you feel confident in the courtroom that what you're testifying to is accurate and was a very objective look at your interaction with the patient rather than something subjective that maybe wasn't totally accurate. So if the SANE's handling the bulk of the documentation, they're going to have more details, they're more likely to testify. And what a SANE does when they are called to testify is very similar to what we recommend you do if you are called to testify. And so we'll go through those few steps here. So if you're called to testify, you're going to want to access your chart. You may need to do that by contacting medical records at your healthcare facility. Every facility has different processes for how exactly you can access your past charting. I can tell you that at least from the nurse side of things, it is often difficult for SANEs to access their old charts. It may be easier for you as a provider, but if you have any difficulty, don't worry. You can also get the chart through the attorney who subpoenaed you because they must have had access to your chart in order to subpoena you, and they are not held to the same HIPAA restrictions, and so can share that back with you more easily. Once you have your chart back in your hand, just look it over, see if anything really stands out to you. If you see any errors, which we're human, we all make errors, it's not the end of the world. Just point it out to the attorney in advance. Maybe you referred to the patient by the wrong name. Maybe the wrong date ended up in there somehow. Maybe there's a conflict on what side of the body a certain injury was. Let the attorney know, see if there's something in the charting that really clearly indicates what was the correct version. And that way they can get ahead of that error and it doesn't become a big issue for you up on the stand. And then just rely on your charting to guide your testimony. If you do have an independent memory of the patient, you can of course testify to that. But again, with the number of patients you see, with the amount of time that's likely to elapse between seeing the patient and possibly going to court, it is unlikely that you will have much of a personal memory. And that's fine. Just rely on your charting. You can testify with confidence to anything you included in your charting. Don't go off and speculate beyond that, and you'll be fine.